Colorectal carcinoma. NB. Colorectal cancer is a major public health problem in the developed world. Increasing efforts are being directed towards early identification of the condition in individuals considered to be at risk. Etiology, pathophysiology, and pathology. There are several conditions that are recognized to predispose to colorectal cancer. Adenomatous polyps of the colon. Tubulovillous adenomas carry an increased risk of colorectal cancer. It is generally felt that colorectal cancer usually develops in pre-existing adenomatous polyps in the colon, Fig. 53. Ulcerative colitis. Patients with a 10-year history of colitis extending proximal to the splenic flexure are at increased risk of colorectal carcinoma. They should be offered surveillance colonoscopy with random pancolonic biopsies to detect dysplastic change. Family history. There is a family history in 14% of new cases of colorectal cancer. Lifetime risk can be calculated based on family history and surveillance recommended accordingly, Table 40. Familial cancer syndromes. There are some rare but important hereditary cancer syndromes. Familial adenomatous polyposis, FAP. Autosomal dominant. Hundreds of adenomatous polyps are seen throughout the colon and evident from an early age. The risk of neoplasia is such that prophylactic colectomy is performed before the age of 20. Hereditary non-polyposis colon cancer, HNPCC. This is inherited in an autosomal dominant fashion and is due to mutations in DNA mismatch repair genes. Individuals at risk are offered colonoscopic screening. Epidemiology. The incidence of colorectal cancer increases with age, and overall has increased over the last 50 years. Colorectal cancer now accounts for 20,000 deaths per year in the UK. Clinical presentation. Common. Change in bowel habit, new onset constipation or spurious diarrhea. Iron deficiency anemia. Rectal bleeding. Uncommon. Large bowel obstruction, constipation, pain, and vomiting. Evidence of metastatic disease, ascites. Weight loss. Abdominal pain. Anorexia. Physical signs. Common. In most cases there will be no diagnostic physical signs. Uncommon. Palpable abdominal mass. Signs of iron deficiency, pallor, koilonychia, glossitis. Signs of metastatic disease, hepatomegaly, ascites. Investigation and staging. Duke's staging of colonic carcinoma, Fig. 54. Blood tests. FBC, iron indices, may demonstrate iron deficiency anemia. NB. Liver blood tests may be normal or there may be an isolated elevation in alkaline phosphatase, may be greater than 1000 U/L, in the presence of liver metastases. Two more markers. Carcinoembryonic antigen, CEA, is not useful for diagnosis but may be useful in monitoring the patient's response to treatment and for the identification of disease relapse. Colonoscopy. Colonoscopy is the investigation of choice. Total examination of the colon should be undertaken, even in instances of proven distal tumors, to exclude the presence of synchronous tumors or polyps. If this has not been performed prior to resection, it ought to be done subsequently. Barium enema may be considered in the elderly or frail, or where colonoscopy has been unsuccessful. Characteristic apple core lesions may be seen, Fig. 55. Liver ultrasound, abdominal CT, MRI. Abdominal CT is now the investigation of choice for identifying metastatic disease. In patients with rectal carcinoma, MRI scanning of the pelvis is used to determine invasion into local structures and determine suitability for resection. Chemotherapy or radiotherapy may be used prior to surgery in metastatic disease to downgrade the tumor stage, so staging should be performed except in emergency settings. Differential diagnosis. Diagnoses listed in Table 41 should be considered. Treatment. NB. It is not necessary to establish a tissue diagnosis before laparotomy if there are signs of impending bowel obstruction. Emergency. Acute large intestinal obstruction is a surgical emergency with a high risk of cecal perforation. Short-term surgery. This is required in most cases of colorectal cancer. The extent of bowel resection depends on the site of the tumor. Attempts are made to resect at least 5 cm of normal bowel either side of it. Palliative approaches. Although surgery is the usual treatment for patients with impending colonic obstruction, stenting of tumors with self-expanding metal stents offers an alternative approach for the palliative relief of obstruction. Long-term or according to stage. Chemotherapy. Treatment with 5-fluorouracil improves survival for Dukes B and C cancers. Radiotherapy. Preoperative radiotherapy to downstage rectal tumors reduces local recurrence but has limited effect on survival. Complications. Large bowel obstruction and metastatic disease are common. Prognosis. Mortality. Prognosis following surgery depends on the histological grade of the tumor and the Dukes stage, Fig 54 and Table 42. Prevention. Identifying asymptomatic individuals with premalignant or early malignant disease offers the opportunity to reduce the associated mortality of colorectal carcinoma. This is loosely referred to as screening, although it may be useful to distinguish targeted screening on the basis of a pre-existing disease, surveillance, e.g. ulcerative colitis, or positive family history, case finding, from population screening of individuals of average risk. Surveillance. Indications for surveillance include previous diagnosis of colorectal cancer, previously identified colonic polyps, high-grade dysplasia, more than 3 adenomas, any polyps greater than 1 cm. Ulcerative colitis, initial surveillance colonoscopy at 10 years, then 3 yearly until 20 years, then 2 yearly until 30 years, then yearly. FAP syndrome, HNPCC or other familial colon cancer syndromes. Case finding. Appropriate in those with a significant positive family history, see Table 40. Population screening. Despite continuing controversy, population screening for colorectal cancer is shortly to be introduced in the UK. This will currently include all those over 60 years of age with a positive fecal occult blood test, and will eventually be extended to include those over 50 years old. Colonoscopy will be offered to all identified individuals at 5 yearly intervals. NB. Colonoscopy carries a risk of bleeding or perforation of 1 in 1,000, which is increased if therapeutic colonoscopy, e.g. polypectomy, is performed. Patients should be advised of this risk, including the potential need for surgery, perhaps colostomy, in such an eventuality.